We'll be taking up the anterolateral wall of the abdomen, and these are your objectives. Okay. As usual, as in any anatomy lecture, you will have to know the surface anatomy, and of course, part of the surface anatomy will be the quadrants, the zones, the regions of the anterior abdomen. Then you have to know the bony and soft tissue surface landmarks, identify the muscles, their attachments, neurovascular supply and functions, and of course included in this anterior abdominal wall discussion is the inguinal canal and its contents. And you will get to know about direct and indirect inguinal hernias. Okay, so these are the boundaries of the anterolateral abdominal wall. Okay, I'm sure you're familiar with all these landmarks.
Excuse
Okay.
me, sir.
Yes, sir.
We're still on the first slide.
What's that?
It's showing only the first slide.
Oh,
So it's not moving.
It's not moving in your... Okay, let me check it, share again. Now, can you see it?
Yes,
No.
Doc.
Yes, Doc.
Okay, so let me go back. If you did not see the objectives. So this is all that you saw. Okay. And this is the next one. Okay. It's not moving. Oh my God. Okay. So these are the objectives that I was talking about. I'm sure you can take the picture very quickly. All right. So pay attention to this objective. This will be your study guide. Okay. And most of your written exam questions will be focusing on this. If ever the dean will choose my questions. Other faculties will be giving questions for your anatomy written exam. Okay. All right. So it is important that you read the references in detail because the questions will be detailed, especially those that we will not be able to cover, like neurovascular structures. So basically, this is just an overview that I'm presenting to you, given the 1 hour time limit for the lecture, okay? For the virtual lecture. All right. So as I was saying, these are the boundaries for the anterolateral abdominal wall. Superiorly, you have the ribs there, numbered 7 to 10, and the xiphoid process. Inferiorly, the inguinal ligament. These are all familiar to you because the inguinal ligament is supposed to be using these landmarks in the pelvic girdle, iliac crest, pubic crest, and the pubic symphysis. Anterior superior iliac spine is also included for you to be able to trace the inguinal ligament. Okay? All right. So these are the bony and soft tissue landmarks. Okay? I hope the picture will come out. So basically the checklist also for identification in the lab. Okay. So that's very quick right there. And this is just to show you the entire abdominopelvic cavity. Okay. The abdomen will be from this point right here in the bracket, abdominopelvic cavity. Okay, because it is one continuous cavity. And there is the pelvic aperture. That is not a physical boundary, but that is the limit for the abdomen and the pelvic cavity. Okay? All right. So just to give you an idea, the perspective as to what part of the body we're talking about. All right? So Moore would like to describe it as the abdominopelvic cavity. All right? But we will be focusing only on the abdomen, where most of the GI tract is located, because the pelvic cavity is where most of the reproductive organs and genitourinary organs are located. All right. So again, this is a GI module. So these are the bony soft tissue landmarks. Okay. I'm sure you're familiar with this. We do not have to go into great detail. right? You're familiar with all those bony and soft tissue landmarks, okay? And just to point out to you, this is the entire position where you will find upon dissection or during surgery the linea alba. It's in the midline, okay? And you will get to know more on the linea alba later. This is just the soft tissue landmark. So linea alba is in this location, okay? And you have there the linea semilunaris. That's the entire linea semilunaris right there on both sides, okay? All right. The bony landmarks are all familiar to you. Needs no repetition, right? Okay. These are the quadrants. I'm sure you're familiar with this. Okay. And you have to be familiar also with the organs of the GI tract that reside in each of these quadrants. For example, the right upper quadrant is where you will find the hepatic flexure of the colon, the liver, obviously, the gallbladder, and the symptomatology of clinical conditions will all be presenting in this right upper quadrant, involving those organs that are located. And of course, the lower quadrant is the most popular since the appendix is located in this quadrant. It's the most commonly operated organ in the body, so right lower quadrant is very easy to remember for everybody, right? You're talking about appendicitis. Okay. And of course, the organs in the left upper quadrant, that will include, as you can see, right there, the stomach, part of the liver, and also the spleen. And of course, more posterior will be the pancreas. That will also include at least this upper part, the epigastric, that we will be taking up in the regions later on. Left lower quadrant, usually the sigmoid and small bowel also. Plus, of course, the descending colon. Now, you have seen the quadrants. Now, you see the zones of the abdomen. And this is how the zones are constructed. You will be needing at least 2 horizontal reference lines. This is subcostal line, inferior border, 10th costal cartilage. And the trans or intertubercular or intercrestal line, depending on the textbook that you read, they're all the same, more or less varying by only a few centimeters. So that's the approximate location of that line, intertubercular or intercrestal line. That's using the axis as the reference landmark, 5 centimeters posterior. So this is anterior landmark, axis. You measure 5 centimeters going posterior. That is the approximate location of the intercrestal line. So those are the 2 horizontal lines. And you can imagine that being drawn. Okay. Oh, sorry about that. Oh, I lost my photos for this. Okay, sorry about that. But that's the subcostal line and then the intercrestal line. Okay. Something's wrong with this slide projection. Okay. So there you have it. Now you divide the anterior abdominal wall into 3, right? 3 regions using the 2 lines, subcostal and intercrestal, the 2 horizontal lines. Okay. Now, to produce the 9 zones, you will need vertical. Okay. So those are the resulting 3 zones. Just using the horizontal lines, you have the epigastric zone, umbilical, and then hypogastric. Those are other names, hypochondriac, mesogastric, and suprapubic. But these are the more commonly used ones, epigastric, umbilical, hypogastric. Or you can also use the term suprapubic or infraumbilical. Okay. Now, to produce the 9 regions, you will need 2 vertical lines, and those are the mid inguinal lines. Or you can also say mid-clavicular, because more or less they're not very much different. So by doing so, you will be producing, okay, this is the mid-clavicular or mid-inguinal point line, vertical. You will produce the 9 zones of the region, and they are labeled as shown here. Okay? The gastric, umbilical, hypogastric, and then added will be your right and left hypochondriac, right and left lumbar, then right and left iliac. So it's really okay, you will see on the superficial fascia of the anterior abdomen. So this is the sequence by which you will see the structures during dissection. So superficial first. Obviously, you have to encounter the skin, subcutaneous tissue, and then this is going deeper, superficial fascia. Above the umbilicus, these are the terminologies. Panniculus adiposus is a thin layer of fat. Panniculus adiposus is simply a layer of fat. Okay. And below the umbilicus, well, the terminology is simply Camper's fascia, the fatty layer, which is more superficial, and Scarpa's comes next after Camper's fascia as you go deeper. And this is the membranous layer. Okay. And then there's also the callus fascia, but this will be discussed further in the module of the pelvis and perineum, surface anatomy and this section of the perineum. Simply because this is an extension. And you have to know the clinical significance. That's a challenge for you. Okay. Anybody give me the clinical significance? Did any among you do any advanced reading prior to coming to class? What is the clinical significance of Cole's fascia? No idea. So I leave this as a hanging question so that you will read in great detail your textbook. Okay, it's all explained very well in Moore's clinically oriented anatomy. Okay, our Bible for anatomy. Okay, for students. Okay, and that's the Cole's fascia that I was talking about in the perineum. Okay, an extension of the Scarpas into the perineum. So as you can see, the Scarpas fascia will change its name once it changes the location, okay, or the distribution of the Scarpas fascia. And that is one example, okay. Scarpas in the perineum is called Cole's fascia, okay. All right. The muscles of the anterolateral abdominal wall, one of the objectives that I have listed. Very easy, right? Just 5 muscles. The recti muscles, the obliques, they're all paired, all present on both sides, right and left. So whenever you're given in the practical questions about this, the correct laterality of the muscle must be indicated, okay? I am always very particular about laterality. And then the transversus abdominis and pyramidalis muscle. There is a nice table also in Moore about all these muscles. Basically, this is what you will see in the tables. Okay, origin for recti muscle, rectus abdominis singular. Okay, pubic crest, pubic tubercle, symphysis. So as you can see, is more inferior origin, and then it will insert more superior to the costal cartilages. Innervation as shown here. Okay, T7 to T12 spinal nerves. Now the action is flexion of the vertebral column. Okay. So this is the disposition in this illustration from Gray's Anatomy of the rectus abdominis muscle and pyramidalis muscle right there. Of course, you will not see it on the other side, just to demonstrate the next layer of muscle right there, lateral to the recti muscles. So as you can see, the central part is occupied by the recti muscles. Okay, this is the right rectus abdominis muscle, and of course, missing is the left rectus abdominis muscle. Just to show you the posterior rectus sheath right there. And the flank muscles, as you can see, is more lateral. Right? You will not find the oblique muscles in the region of the recti muscles. So this is exclusive. This region is exclusive for the recti muscles. And in well-developed individuals like athletes, okay, these will be seen as what you commonly hear as the six-pack. Okay, why? Because the recti muscles are intersected by these tendons, as you can see, tendinous intersections, transverse intersections, producing the six-pack, those with very minimal fat on the anterior abdomen. Okay. All right. So you can see here nicely the layers of the flank, the thin muscles on the lateral wall of the anterior abdomen. Okay, external oblique right there. And then the comes next will be internal oblique. Okay. And what else? Yeah, the pyramidalis muscle is also seen in this illustration. Okay. So there you have it. This was taken from Gray's Anatomy for students. And you can also see this in Gray's Atlas of Anatomy. So these are the three parts of at least you should take note of the composition of the rectus sheath. Okay, above the rib margin to linea semicircularis, or the semicircular fold of Douglas, and the level of the linea semicircularis to the pubis. Okay, the layers will vary depending on the location, as shown in these three parts of the rectus sheath. Okay, those are the number of layers that you will see. As you can see, at the most inferior part with this semicircular line or linea semicircularis as the landmark, you will see that the two layers are missing. Okay, as you can see, the posterior is just one layer. Whereas as you go above the semicircular line, you have the complete layers. Okay, and the exception again will be the once this rectus sheath reaches the costal cartilages. Okay, sternal oblique right there, origin, insertion, innervation, action. All right, those are the attachments. And this is the disposition of the external oblique muscle. Okay, purely the illustration showing the external oblique. Take note of the direction of the fibers. So during dissection, you will see these fibers if you dissect carefully. Okay, and you will see here the aponeurosis of the external oblique, forming a condensation, a thickening that forms the inguinal ligament. Okay, consider the inguinal ligament attaching to the anterior superior iliac spine up to the pubic tubercle. It's not very clear, but it will be attaching the pubic tubercle right there. Atomic landmark will be symphysis pubis and then the pubic tubercle. At least you can see also here the external ring of the inguinal canal. Okay, so external ring and the internal ring is somewhere there, just to give you an idea as to when we go to the discussion of the groin hernias later. Okay, so that's the significance, clinically at least, of the external oblique muscle and its aponeurosis. Okay, both sides. in terms of the formation of the inguinal ligament right there, and forming part also of the inguinal canal. All right. A closer view now of what I was talking about. You see there the attachment of the external oblique aponeurosis. I'm emphasizing this simply because this is clinically significant. Okay. So you have to know the anatomy of the groin. This is part of the anatomy of the groin. If you have to understand the clinical entity known as the hernias, the groin hernias. Okay, anterior superior iliac spine right there is the landmark where it will attach superiorly then inferiorly to the pubic tubercle, and as it meets with the bony structures right there, then it will be the extension forming the lacunar ligament. So there are simply folds of aponeurosis right there that forms those different named ligaments. There are many more. This is a simplified drawing just to emphasize the formation of the inguinal ligament in relation also to the major vessel as shown here, the femoral artery and vein. Okay. All right. And this is shown also to emphasize the fact that anatomically this is an important landmark, okay, the inguinal ligament, because beyond this, your iliac vessels becomes femoral in nomenclature. Okay. So this is simply a continuation of the iliac vessels. All right. Internal oblique. So this is the anterior half of the iliac crest, lateral two-thirds of the ligament, lumbodorsal fascia as the origin. Insertion, outer surface, last three ribs, linea alba and pectineal line of the pelvic girdle. Now, innervation, almost the same for all. T7 to 12, and then L1. Again, flexion and rotation of the trunk. Provides also compression and support to abdominal viscera, especially when you do the Valsalva maneuver. So this is the illustration showing the disposition of internal oblique muscle. The same photo that, the same illustration I showed you earlier, but this time the other side is intact. Okay. So external oblique right there, followed by the internal oblique. Take note of the direction of the fibers. Okay. Very much different from the direction of the external oblique. Now the transversus abdominis. Those are the attachments, origins. And only one insertion point, the linea semi-lumnaris, okay, on the anterior abdominal wall. Again, increase intra-abdominal pressure is the action, anterior or lateral flexion of the trunk. So this is the transversus. You see there the cut layers of the external oblique, internal oblique, and then you will find the transverse fibers of the transversus abdominis muscle and aponeurosis. You will see that they will all be condensing, meeting at the center to provide a aponeurotic cover for the recti muscles. They form the rectus sheath. So these flat muscles on the lateral aspect of the anterior abdomen contribute to the formation of the rectus sheath. Okay, that's the linea alba right there. It's the condensation of the aponeurotic layers being contributed by the flat muscles. Okay, so that's a linea alba right there. So we call this from xiphoid to pubis as coast to coast. Whenever we do the surgical incision, it's a coast to coast incision. The long incision in emergency surgery. Okay, you open this up, and it is providing quick access to the abdominal organs in trauma. Okay, and it is bloodless. Okay, so quick access and bloodless. Okay, so this illustration from Moore will show you all about this direction of the fibers that you have seen earlier. Okay, so this is the external oblique. You see the direction will be going downwards from its superior attachment right there, and the internal oblique will be showing this manner of direction of the fibers. Okay, see that the lumbar fascia as the attachment for the internal oblique, whereas the external does not have that attachment. Okay, and likewise, the transversus muscle also has a lumbar fascial attachment right there, and you can see the transverse fibers. So it's very easy. Okay. Now the cross section above the arcuate line. All right. So these are the layers, okay, of the rectus sheath that are being contributed by the external oblique, internal oblique, and then the transverse abdominis muscle. Okay, you can see that the condensation wrapping around the recti muscle. Rectus abdominis here, rectus abdominis also. Yeah. So if you will be doing incision, for example, in the midline, through the linea alba, you will not encounter all these muscles. Simply just the condensation of the fascial layers contributed by the flat muscles of the flank. Okay, for that reason, it is bloodless. Okay, it's the same. Below the arcuate line, you see the difference now. So what is missing right there? Okay, will be that posterior layer. Okay, see, there is no posterior rectus sheath below the arcuate line. Okay, again, you see there is a posterior rectus sheath above the arcuate line, but below the arcuate line, there's no posterior rectus sheath contributed by the flat muscles. So I just want to highlight that important difference using the landmark arcuate line. Now the pyramidalis, this may or may not be present. Okay, so it's absent approximately 20% of the population. That's the origin, anterior to inferior part of the rectus abdominis. So it's more closely associated with the surface of the pubis, anterior surface of the pubis, anterior pubic ligament, and ends in the linea alba. So the fibers really proceed medially to the linea alba. Tenses the linea alba, and this is what surgeons use, okay, the attachment of the pyramidalis to take note of the landmark for the median abdominal coast-to-coast incision. Okay, so that's the linea alba right there. Okay. Well, in this illustration, you will also see the blood supply. Okay, and innervation coming from the intercostal nerves, supplying the anterior abdominal wall. Blood supply to the rectus abdominis muscle on the left, okay, is shown here in this dissection illustration that has been dissected to reveal the blood supply to the rectus abdominis muscle. You see there the superior epigastric vessels, inferior epigastric arteries. Okay, arteries and veins. Okay. Now, innervation, anterolateral abdominal wall. Okay, that's the distribution. All right. So basically, lateral cutaneous branches are identifiable in this illustration from 7 to 12. Okay, T7 to T12. Okay, and then, of course, your other nerves as labeled here, L1, iliohypogastric nerve coming from lumbar 1. Okay, ilioinguinal also coming from L1. So those are the anterior cutaneous branches of the corresponding spinal nerves. Superimpose on surface anatomy landmarks. Okay. This is the dissected picture, and this is the surface anatomy superimposition. Okay, all right. So the blood supply to the anterolateral abdominal wall. Superficially, you have the musculophrenic terminal branch of internal thoracic. Inferior wall will be superior epigastric and superficial circumflex iliac artery. Both branches coming from the femoral artery. Okay. Okay, so as you go deeper, the superior wall is supplied by superior epigastric terminal branch of internal thoracic artery again, and lateral wall 10 to 11 intercostal arteries. So you can see the intercostal contributing, and also the subcostal artery contributing to the lateral wall. Inferior wall, inferior epigastric artery, and the deep circumflex iliac artery, both branches of the external iliac artery. So basically, those are the arterial, the named arteries for the superficial and the deeper level of the anterolateral abdominal wall. Okay, so this is the illustration from Gray's Anatomy again, showing you the arterial supply. Okay, that's a major source right there, internal thoracic. That's the disposition of internal thoracic. You can see there. Para-external location. Okay, it's behind those costal cartilages. Okay. All right. So these are the epigastric vessels, okay, being emphasized in this illustration. Okay, so that's your arcuate line right there, important anatomic landmark. Okay, remember the anatomy of the rectus sheath. So that is the landmark where you will find no posterior rectus sheath, okay, below the arcuate line. Okay, so that's your superior epigastric artery, inferior epigastric artery. They have different major blood vessel source. Now the veins, okay, anterior abdominal wall, these are the named veins. Superficial, supraumbilical, infraumbilical, paraumbilical, thoracoepigastric. Okay, so the paraumbilical veins are also called the veins of Sapi. Right, this is another name that you might come across in your readings. So there you have it, the paraumbilical veins. Okay, all right. Superficial veins of the anterior abdominal wall. Illustration coming from Moore, the older edition of Moore. Lymphatic drainage, superficial lymphatics. You see the names, supraumbilical, infraumbilical, simply because they are using the transverse umbilical line, okay, as the reference landmark. Okay, so above the umbilicus, it will drain to the axillary nodes. Below the umbilicus, it will drain to the superficial inguinal nodes. And the deep lymphatic vessels drain to the external iliac, common iliac, right and left lumbar lymph nodes. So there's a manner in which the lymph is drained on the anterior abdominal wall. And this is it in this illustration from Moore again. The lymphatics, superficial veins, anterolateral abdominal wall system. Okay, that is the reference landmark that I'm talking about. Transumbilical plane, a horizontal line, okay, using the umbilicus as the reference landmark. So above this, axillary lymph nodes will be the main destination of the lymphatic drainage. And below the umbilicus, it will be the inguinal lymph nodes. Okay, so this is an important part of this illustration, just to show the bypass, okay, from femoral vein to axillary vein. Should there be any obstruction along its path on the way to the, since this is a tributary of the vena cava, any problem in the, or any obstruction in the inferior vena cava, this will be very prominent, since this is a very superficial blood vessel. This can get huge and tortuous on the subcutaneous layer. As you can see, this is fat, so it is located subcutaneously. So this will be very prominent for any pathology or any obstruction along the path of its drainage, the femoral vein to the vena cava system. Okay, so that vein, the venous system of the thoracoepigastric, okay, that will be the bypass that will allow drainage, okay, from femoral vein to the axillary vein and then to the heart. Okay, the posterior aspect of the anterolateral abdominal wall. Okay, it is described as being covered by transversalis fascia, extraperitoneal path, parietal peritoneum. So we're talking about the posterior aspect of the anterior abdominal wall. You're looking at it from the inside. Okay, very much similar to a laparoscopic view. Okay, when you insert a camera through the abdomen, through tiny holes, this is what you will see when you look at the posterior aspect of the anterior abdominal wall. Okay? All right. So that's the very first thing that you will see in a laparoscope, the glistening parietal peritoneum. Okay? Followed by the preperitoneal fat in that order, from inner going to the surface of the skin. Okay? So overall, you will be looking at the falciform ligament. It's very prominent. Okay, so this is sagittally oriented, peritoneal reflection. See, falciform ligament is not a true ligament, but this is peritoneum. Okay, but it has condensed to become more or less similar to a ligament. So this extends between superior anterior abdominal wall and the liver. Okay, so this is an attachment on the anterior abdominal wall and then also to the liver. And in the falciform ligament, you will find the round ligament of the liver. Okay, the ligamentum teres. And that is the remnant of the umbilical vein. Okay, the round ligament of the liver contained in the falciform ligament is the remnant. Okay, so this is an embryologic structure. Remnant of the umbilical vein. Then you will have the paraumbilical veins. The infra-umbilical part, you will see this. Very important anatomic landmarks, especially during dissection. You can identify the median umbilical fold, so that's one. Then you have two medial umbilical folds, that's lateral to the median, both sides. So you have right and left medial umbilical folds, and the two lateral umbilical folds. Okay, so the medial umbilical folds, as you can see here, do not have any vital structures, only the remnants also, or the occluded umbilical arteries. The median umbilical fold is a remnant also of the urachus. Okay, so that join the apex of the fetal bladder to the umbilicus. Okay, so that's the urachus. So The only umbilical fold that contains a vital structure is your two lateral umbilical folds. So this is clinically significant. So those folds contain the inferior epigastric vessels. We've been talking about the inferior epigastric vessels early on. You have seen these vessels in the previous slides, and this is also clinically significant, especially to surgeons doing groin hernia surgery. And you will get to know about this clinical significance later when we go to groin hernias. So this is what we're talking about. This is the dissected posterior surface of the anterior abdominal wall. Okay, you will see there the inferior epigastric vessels originating from the iliac vessels. Okay, then as it proceeds to supply the branches of the inferior epigastric vein and artery, the posterior aspect of the rectus abdominis muscle, as shown in this representative cut section of the right rectus abdominis muscle, and the posterior rectus sheath has been opened right here, just to show you the landmarks. Okay, the arcuate line is there. Okay, and that is an important landmark where you will see the blood supply entering the posterior aspect of the rectus sheath, rectus abdominis muscle. Okay. So I guess that's my last slide for the anterior abdominal wall system. There are many more topics to be taken up in the anterior abdominal wall system, but this is the summary slide. I hope you were paying attention. But basically, we have covered at least the 9 layers of the abdominal wall. So this is a summary slide. So when a surgeon makes the skin incision, okay, the surgeon will encounter next the subcutaneous tissue. Okay, this is considering that these layers of the muscles are encountered in the incision. Okay, just to give an example of how this is organized in the anterior abdominal wall. Okay, skin, subcutaneous tissue, superficial fascia. Okay, then external oblique muscle, followed by internal oblique transversus abdominis muscle. So that's the muscle group. You will do the incision hitting these muscles. Okay. Otherwise, if it's more medial, then it's just the rectus abdominis. Okay. Then transversalis fascia, peritoneal, adipose tissue, and the peritoneum. So most textbooks will describe that as the 9 layers of the abdominal wall, lateral to the rectus abdominis muscle, the recti muscles. But there is also what is known in surgery as the rectus incision. Okay, so you can also split the muscle fibers of the rectus abdominis, and you can make your incision right there. But of course, that will be very bloody if you will not avoid you can hit the inferior epigastric vessels. So it is not advisable to do that incision because it can be very bloody. So let's go now to the inguinal region. It's clinically significant area below the level of the anterior superior iliac spine, above the inguinal sulcus. Inguinal sulcus is simply the depression of the skin. So that is also an important anatomic landmark that will signify that you are already in the region of the inguinal ligament. Okay, inguinal trigone, inguinal ligament, as the one forming part of the boundaries of the trigone, meaning it's a triangular area. So try to imagine the inguinal ligament inferiorly, then lateral margin rectus abdominis, medially, and then horizontal line from axis superiorly. So that makes up a triangular area. Okay, I hope you're using your imagination, trying to make the drawing of the inguinal region. I think I'll give this as one of the objectives for the laboratory tomorrow, right? Tomorrow evening will be your laboratory for this. So make sure you know how to make the drawings for tomorrow. But I will be giving you only maybe 5 or 6 objectives, and each objective you are required to make at least 3 drawings. So you really have to work fast tomorrow. Okay. By the way, is it your class who submitted the drawings in our last laboratory? No, I don't think so. All right, so that's 1B. I think that's 1B. And most of them, they submitted only 1 drawing per objective. So most of them failed in their laboratory grades. Okay, so again, pay attention in your drawings for the laboratory tomorrow. Make sure you submit at least 3 drawings per objective. Okay, so this is the definition of the inguinal canal, described anatomically as 4 to 5 centimeters long, directed to the muscular. These are just the textual description. You can read this in the textbook. It's better seen in the illustration. You see there, the deep inguinal ring and the approximate location of the external ring right there, that makes up your inguinal canal. Okay, and obviously that's where you will find the spermatic cord. So these are approximate locations in this illustration from Gray's Anatomy. Okay, pay attention to this anatomic relationship of the inferior epigastric artery, the very famous vessel that is clinically significant, I told you, remember? Inferior epigastric. So you can see here the deep ring is lateral to the inferior epigastric artery. Okay, it's lateral to the inferior epigastric artery. And that anatomic relationship is very important in determining whether the groin hernia is direct or indirect. Okay, so this early I'm telling you that all bulges or protrusions lateral to the inferior epigastric artery, okay, is called indirect hernia. Okay, indirect inguinal hernia. And all bulges medial to the inferior epigastric artery is called direct hernia. Okay, so I'm sure you must have guessed by now that during physical examination you cannot make the diagnosis of direct or indirect. But since indirect is more common, more commonly encountered, then you can make a working diagnosis of indirect inguinal hernia. The final diagnosis, the final determination as whether this is direct or indirect is during surgery. Once the surgeon has exposed the proper anatomic relationship. Okay? All right. So this is the superficial inguinal ring. You can see there. I told you earlier that this is formed, okay, mostly by the aponeurosis of the external oblique. Okay, you can see there the aponeurosis of the external oblique. That's the muscle right there. Okay. That's the spermatic cord exiting the superficial inguinal ring. This is the inguinal ligament at some point in the middle, so mid-inguinal point of the mid-inguinal ligament is where you will find the internal ring. Okay, so that will be the extent of the inguinal canal. All right. So these are the contents of the inguinal canal. I leave it up to you to know the boundaries of the inguinal canal, how it's formed, but you have seen there the one boundary, which is the external oblique aponeurosis. You supply the rest, okay? So you have to do more detailed readings on the inguinal canal formation. You have to know the boundaries. So these are the contents, comparing the male, okay, contents of the inguinal canal with the female contents of the inguinal canal. Okay, we don't have much time, so I have to proceed quickly. Now this is what is known as a Hasselbalch's triangle. Small triangle. Boundaries are as shown: linea semilunaris, medially, inferior epigastric vessels laterally, medial end of the inguinal ligament inferiorly. And I'm sure you know by now the clinical significance of Hasselbalch's triangle. Okay, you see this anatomic landmark: inferior epigastric vessels laterally. So, can you tell me now what type of inguinal hernia will you find in the Hasselbalch's triangle? Anybody? You were listening closely, you know the answer to that.
Direct hernia.
So the answer begins with what? Letter D or letter I? You're saying direct. Yes? Hello?
Indirect hernia.
So the beginning letter to the answer is I.
Yes.
Any
Yes, sir.
other opinion? Pay attention. Inferior epigastric vessels laterally.
Direct hernia.
Now you're changing your answer. Explain why it is direct.
Sir, if the hernia is present laterally to the inferior epigastric, that is called the indirect hernia. And if hernia present in the superficial inguinal ring, that is medially to the inferior epigastric vessel, lead to direct hernia.
Okay, very good. Well said. So do not be confused by this term here. If you know your anatomy, then you will know the correct answer. Okay, very good. Thank you for that answer. And this is it. This is what we're talking about. You see here the inferior epigastric vessels. And this is the Hasselbalch's triangle that we're talking about. Okay? This triangle right here, sorry. These are the reference landmarks. See the rectus abdominis? Okay? So this is the triangle that we're talking about. That's location of the superficial ring. This is the inferior epigastric vessels. So that makes up the triangle right there. Okay, so that's your Hasselbalch's triangle. So this triangle of weakness is where you'll find most commonly the direct inguinal hernia. Okay. So this is the illustration from the posterior aspect of the anterior abdominal wall. Okay, I hope I'm making sense and you are appreciating the view that you're looking at. All right, because the next slide will show you the same in the laparoscopic view, but this time with the direct hernia, simply because this is your Hasselbalch's triangle. Okay? All right, so pay attention to the other anatomic relationships in the region. Okay? That's it. That's your Hasselbalch triangle. In the clinics, this is how these hernias will present as bulges. Okay? Along the region of the inguinal ligament, you will see these groin hernias, whether it's direct or indirect. Like I said, it will be up to the surgeons to declare that, not during physical examination. Okay, you can just say in your report on the physical exam that is a groin mass. Okay, most probably indirect inguinal hernia. You can say that simply because it's more common than direct. And if you can appreciate the exact location as in here, about the region of the Hasselbalch's triangle, then you can say it is direct hernia. Okay. But in practice, this is what you will see. Okay. You also see in the female femoral hernia. Okay. Take note of the location. And Okay, this is an indirect inguinal hernia as proven during surgery, but then in the clinics, you cannot say whether this is direct or indirect. Okay? Because the anatomy is very much distorted with a very large scrotum, okay, containing intestines. And this is umbilical hernia. Okay? So most of these are acquired. And for congenital hernias, umbilical hernias, it is failure of closure of the umbilical ring. So this is common in males and premature infants. Whereas for adults, like I said, this is an acquired condition, especially those with cirrhosis, those who are obese, those who are malnourished, and those who have ascites. Okay, very quick look at the abdominal cavity and peritoneum. These are the objectives. We have how much time left? About 2 minutes. So pay attention to the objectives again. Make sure you differentiate. You know how to identify these terminologies used. It's all about the peritoneum, okay, and the peritoneal folds, functional and clinical significance, okay. All right, again, for perspective, that's where we are, peritoneal cavity, okay. To include the pelvic cavity, which is continuous with the peritoneal cavity. So by definition, this serous or mesothelial membrane lining the abdominal wall is called parietal, and lining the organs, visceral, peritoneum. Now, the cavities, you have to know the greater peritoneal cavity and lesser peritoneal cavity, also called the omental bursa. Okay? So this illustration from Gray's Anatomy will show you the anatomic relationships and the formation of the omental bursa. Okay? You see there the omental bursa, the organs involved in the formation of the bursa. That's your lesser omentum. So there is a potential space. The spaces here is exaggerated. But in actual live patient, of course, these are not this wide. Okay, this is a potential space. These spaces are potential spaces. Okay, simply because the abdominal organs are tightly packed, and you will not be able to appreciate this. Okay. All right. So there you have it, the greater sac. Okay, and that's where you will find the greater omentum. Take note of the attachments of the greater omentum, stomach and transverse colon. Okay, so it's a double fold of peritoneum that makes the greater omentum. Okay, so the transverse view, transverse section, very similar to the CT scan section, that level, above the umbilicus. This is what you will see. Okay, so the lesser omentum, and this is entered by the foramen of Winslow. There's an opening right there, the omental foramen of Winslow. Okay, and once you insert your finger here in this opening, you can palpate this portal triad. Okay, the bile duct right there, coded green, the portal vein, and the hepatic artery. Okay. So that is the concept of the anatomic concept of the foramen of Winslow. Okay, more definitions. You've seen the lesser sac and greater sac. Now this is lesser omentum and greater omentum. And the mesentery contains obviously the blood supply to the intestines. And in the case of the colon, it's called mesocolon. Mesentery proper for the small intestines and mesocolon for the large bowel. This is it, the disposition of the greater omentum. Once you open up the abdomen, this is what you will see, the very first structure that will greet you or not the intestines, but the greater omentum. Okay. So the greater omentum has been lifted just to show you the association and the attachment to the transverse colon. Okay, more peritoneal reflections, descriptive terms, the peritoneal ligament, peritoneal folds, peritoneal recess. Okay. The function of the greater omentum, I'm sure you know that by now. It is considered as the abdominal policeman, simply because for any region or area where there is infection, it will try to cover it with omentum. So the posterior abdominal wall system just focus on these objectives, the muscles, the fascia of the posterior abdominal wall. Well, not so much on the diaphragm, but then it's included in the objective, one of the objectives. And again, finally, the neurovascular structures of the abdominal wall. Okay, so what makes up the posterior abdominal wall? 5 lumbar vertebrae, okay, abdominal muscles, posterior, diaphragm, the fascia, lumbar plexus, and NBS, plus fat and lymph nodes. These are the muscles, okay, very nice table also is seen in humor. As shown here, okay, origin, insertion, innervation, you have to know all this, unfortunately. And that's the disposition of those structures in the posterior abdominal wall system. Take note of the attachment to the vertebral column for the iliopsoas group. Iliopsoas, the psoas major, psoas minor, the acus makes up the iliopsoas group. So the diaphragm, very quickly, those are the origins, okay? Crural origin, costal, sternal, medial. So it's all around the entire abdominal wall cavity. Now, there's only one common insertion point, which is the central tendon. Okay, now that's the innervation for the diaphragm. The illustration from Grace showing you the view from the abdomen. You're looking at it from the inferior aspect of the diaphragm. So those are the important levels for the openings of the vital structures. Inferior vena cava, 8 thoracic vertebra, esophagus, 10 thoracic, aorta, 12 thoracic, and the thoracic duct is located at about the 12 thoracic vertebra, plus the cycus vein also located at that level, begins at that level. Okay, so that's the diaphragm. Another view from the superior aspect. As you can see, this is the pericardial sac from the superior aspect, and that is just to show you the central tendon. Okay, the common insertion point for the diaphragm. Neurovascular structures as listed. See, the entire abdomen really is a very long topic, and you cannot cover all of them in 1 hour. So I guess I leave this up to you to know all this. I think we ran out of time. It's past 9 p.m. and I'm sure you have other assignments to do. Okay, so I would like to end the session here, and good luck on your written exam. Okay, so thank you for your attendance.
Thank you, Doc.
Okay.